Light on, I'm afraid.
Just a minute. ¿Qué tal? Muy buenas tardes a todos. Es un gusto para la Asociación Mexicana de Cirugía de la Mano el contar con la presencia del doctor Lalonde. Él es un destacado cirujano plástico de Canadá, quien ha puesto en boga la técnica de Walant, la cual nos ha permitido a muchos cirujanos utilizar esta técnica y tener un acercamiento y un enfoque diferente, el no tener que usar la isquemia, los torniquetes, esto en base a la utilización de gilocaína con epinefrina, que antes éramos muy reacios a la utilización de esto. Entonces, de tal manera que quisiéramos que disfrutaron de esta plática del Dr. Lalonde. Dr. Lalonde, welcome to the transmission for the Mexican Association of Hand Surgery. It's our pleasure. Thank you very much for your time. This is your time. Thank you very much.
Muchas gracias, Dr. Bonfil. Es mi gran placer de hablar con vosotros. It's a great honor for me to speak to you. I'm so sorry that my Spanish is not good enough to speak to you in Spanish, but please forgive my English.
Don't worry. Okay, this is your...
Are you seeing my presentation? Can you see?
Yes, I can see, but it is not the first slide.
No, this is the second slide now.
Okay.
Yeah. So is this going to everyone? Can I continue speaking?
Yes, you can.
Perfect. So there is a Wide Awake Hand Surgery book. It's a very good source of information with over 150 videos. And I make no money on the book. All of the money goes to promoting less unnecessary costs and unnecessary garbage in hand surgery. And this is a website, walant.surgery. I make no money on the website. This website is free for all hand surgeons and hand therapists in Mexico. You just log into walant.surgery and you will see a lot of information. So I would like to tell you 3 true stories that may change the way you do hand surgery. And the first story is that you do not need any sedation or a tourniquet to do most hand surgery. And Walant is wide awake local anesthesia, no tourniquet. We only use lidocaine and epinephrine, tumescent local anesthesia, wherever you will cut. I will explain tumescent. And especially for flexor tendon repairs, for surgeries in which you see movement, it's very, very helpful. But even in surgeries where you don't need to see a lot of movement, it's very, very helpful. And I'm going to explain why you can use Walant for almost all hand surgery. The first tip, do not be afraid of a lot of volume of local anesthesia. Tumescent means big volume. It means enough volume that you can see the local anesthesia under the skin and you can feel the local anesthesia underneath the skin. You should have 1 to 2 centimeters of visible and palpable local anesthesia beyond wherever you will dissect. This is like an extravascular beer block, but only where you need it. So if you put 40 milliliters of 0.5% lidocaine with 1 in 200,000 epinephrine on the volar wrist and on the dorsal wrist, you can do anything to the wrist, including a proximal row carpectomy. Here you see Dr. Carlos de Pina from Portugal doing a proximal row carpectomy. And he's seeing the patient move actively during the surgery so that he can see which parts of the carpal bones are rubbing against the radius. And he can do additional procedures if he wants to, because the patient is actively moving during the surgery. See the patient actively moving the wrist? That's not him doing it. He's watching the patient move. And so this is very, very helpful for so many operations, to watch the patient move during the surgery. This is a video from Dr. Abitbol from France that was posted on LinkedIn just recently. If you look at LinkedIn, you will see many videos from all around the world. So this one is a lunate dislocation. And here Dr. Abitbol has injected a lot of local anesthesia, just as I showed you. He reduces the lunate bone. Then he gets the patient to actively move the lunate bone while he looks under fluoroscopy and sees the lunate is reduced. He then puts a K-wire across the scaphoid and then screws the scaphoid and then puts 2 additional K-wires to stabilize the scaphoid and lunate positions. Then he gets the patient to actively move. And you can see on the fluoroscope up above the scaphoid actively moving with the screw and the 2 K-wires in it. And you can see how stable your fixation is. So after you fixate bones, you can see how stable the fixation is. This is a patient who has a severe Dupuytren's contracture of the PIP and DIP joint. When we do this operation awake, we can see how much active extension he has. This joint is completely released passively, but look at how little extension there is actively, because the MP joint is hyperextended. When we show the patient that his PIP extension is much better with a relative motion flexion splint, he understands why he needs to wear the
so we can
splint
see it on this side.
starting at 3 days after surgery, so that he can
Beautiful.
get a better result. So he goes home and looks after his wife who has Alzheimer's. I know exactly what he's going to do at home because I talked to him during the surgery. Here he is at 2.5 weeks after surgery. And because he did wear the relative motion flexion splint, his result is much better. And here's his final result at a year after surgery. Partly because he was awake during the surgery and I could explain to him why a relative motion flexion splint would give him a better result. And I understood what he was going to do at home because he told me his life story during the surgery. A lot has changed in flexor tendon repair in the last 19 years. In a clean-cut flexor tendon, in a cooperative patient, we should get a good result with no rupture and no tenolysis almost every time, just like in free flap surgery. When I was a young surgeon, I did not get results like this. My results were terrible. I want to show you how we got this result in this 16-year-old. The first thing we did is to inject 10 milliliters of local anesthesia in the palm without moving the needle. This blocked all of the common digital nerves. I then went and saw 5 other patients while the common digital nerves became numb. I came back 30 minutes later and injected 5 milliliters of lidocaine with epinephrine in each proximal and middle and distal phalanges. So 2 milliliters in the middle phalanges, 2 milliliters in the proximal phalanges, and 1 milliliter in the distal phalanx. He did not feel any of these because they were numb. The purpose of these injections was to get epinephrine in the finger so that we would have good vasoconstriction. With epinephrine vasoconstriction with no tourniquet, it bleeds. You have to tolerate 2 or 3 red blood cells. I know you can do it. Just ignore them. By the time you sew the flaps back, the bleeding has stopped by itself. I don't use cautery to do these cases anymore. We just let the bleeding stop. We do these in the minor procedure room outside the main operating room. This was done with field sterility outside the main operating room. I will show you the evidence for that later. If you're doing flexor tendon repair, it's very important to vent the pulleys. Here you are seeing me cut the A4 pulley on the table, just like Jin Botang says to. And there's no clinically significant bowstringing during the surgery, and there's no clinically significant bowstringing after the surgery. It is a myth that you cannot cut the A4 pulley. You can cut the A2 or A4 pulley, but not both at the same time. If you have not read Jin Botang's paper from 2017, which I sent you, Dr. Bonfil has sent you a number of papers. This is one that we sent you. You need to read this paper. It's extremely important. The new rule, forget, don't cut A2 or A4. This rule is passé. It is finished. It is with the dinosaurs. The new rule is don't cut more than a total of 1.5 to 2 centimeters of pulley to avoid clinically significant bowstringing. Let me show you a couple more examples. In this case, I vented A3 plus A4. A2 is intact. There is no clinically significant bowstringing during the surgery, and there's no clinically significant bowstringing after the surgery. In this case, I completely vented A2. I completely cut A2 and A1, and I repaired FDS and FDP. And there's no clinically significant bowstringing on the operating table. Here he is at 3 weeks after surgery with true active movement. And here he is at 12 weeks after surgery, no clinically significant bowstringing. And I have completely vented A1 and A2. As long as you don't vent any more than 2 centimeters of total pulley, you will not get clinically significant bowstringing. Listen to Jin Botang. Listen to Dr. Maria. Listen to me. You can vent short amounts of the pulley, enough that the tendon repair can glide completely with full fist flexion and extension. So this is what we do. Here you see me cutting A4. I repair the tendon, and now I look and see if the cruciate pulley is in my way. I look and see if A3 is in my way. In this case, the cruciate pulley is stopping the repair. A3 is not stopping the repair. So I can preserve A3. I cut A4. There's no clinically significant bowstringing on the table, and there's no clinically significant bowstringing at 3 months after surgery. So you incrementally cut just what you need. You don't cut more than you need. Can you please mute your computer? Someone is making a lot of noise. If you could please mute your computer, thank you. I used to think that the repair on the right was a good repair, and I am embarrassed to say that I published this repair on the right. This is a grandma kiss repair. This is like how you kiss your grandmother on the cheek. The tendon ends are just touching. This is not a good repair in 2021. If you read Jin Botang's paper from 2017, please read his paper. This is a good repair, and this is taken from that paper. And bulkiness is important to prevent gapping and to prevent rupture. If you make a bulky repair like this one, it easily will glide in the vented no pulley zone. And when the forces of active movement start, a bulky repair will not make a gap and it will not rupture. Let me show you an example of a grandma kiss repair that gaps and would rupture at surgery if it had a motor block or if it was asleep. This lady has just had her FPL repaired. She's wide awake on her belly because it's easier to do an FPL. Look at that repair. Looks beautiful. No gap. But as soon as I test it for the first time, there's a gap because the suture bunches in the tendon. And then you get a gap. If she had been asleep, that would have ruptured. But because she's awake, I saw the gap, I fixed the gap, and she did not rupture. Every time you do a flexor tendon repair with a tourniquet, asleep, or with sedation, you risk 7% more ruptures than if you did them wide awake. This is why most Americans and most of the world are starting to do flexor tendons awake so that you can see the gap when the patient tests the active movement. I want to show you another example of how wide awake surgery saved this patient from rupturing. So this is a 6-strand repair, and here's the second pulley. So we actually put the thumb through 2 pulleys, this one and this one. And now we're going to take the needle out, and we're going to ask her to flex her thumb. Now it's very hard. Yeah, there you go. Do it slowly. Great. And straighten out. I was heartbroken to see my beautiful repair come apart with the hard pulley edge. The 6 strands were still there, but the tendon was flipped up. The pulley had actually pulled my repair apart. I'm going to show you that again with slow motion. There it comes down. You see the repair that's torn apart right there. You see the pulley come between the 2 ends of the tendon in my repair. This definitely would have caused a rupture, but we recognized it, cut the pulley, redid the repair, and did not rupture. So I decided to cut the pulley. There it is right there. Left the proximal pulley that I had put the tendon through, but cut the distal one. Then I put in another 2 strands. So now I have an 8-strand repair and then another epitenon suture. So in this situation, I prevented the rupture because the patient was awake. When you do these patients asleep or with sedation, with a tourniquet, you're going to get ruptures in cases like this. 7% of your cases are going to rupture. And we know that from a series of over 100 cases where we saw gaps during the surgery, just like this one, and repaired them. So during surgery, you get the patient to do full fist flexion and extension testing. And that helps you avoid rupture because you can see gaps, and it helps you avoid tenolysis because you can see that you need to vent the pulleys. If the repair does not fit through the pulleys today, it's not going to fit through the pulleys in 3 months. Jinbo Tang and I almost never have to do tenolysis anymore. Walant has also taught us a lot about postoperative hand therapy. Here's another case of 3 cut flexor tendons during the surgery, 4 days after the surgery with up to half a fist of true active movement, and 6 weeks after surgery. No more Kleinert rubber bands, no more full fist place and hold. The best form of postoperative therapy is up to half a fist of true active movement after immobilization and elevation for 3 to 5 days after surgery. So the first 4 days after surgery, up, quiet, over the heart, like a sleeping baby. Don't try to move it because it bleeds inside if you try to move it. The blood turns to scar. If you keep it up and quiet, all the swelling comes down, the patient gets off all painkillers, and the work of flexion is less, and then they listen to their pain. They just can't do what hurts. Pain-guided therapy, pain-guided movement. This post-op regime is in Jinbo Tang's 2017 clinics paper that I sent you, or you can Google the St. John flexor tendon rehab protocol, and both are on the walant.surgery website. This is very helpful for your hand therapists. Walant has taught us that we only need up to half a fist of true active movement to get 5 to 15 millimeters of profundus glide. You can Google this paper and see that. We don't need a full fist. We don't need full fist place and hold anymore. I still get occasional ruptures. This patient had a beautiful result on the table, but he ruptured after surgery because he was a drug addict, and I did not talk to him during the surgery. I was too busy teaching my residents during the surgery, and I ignored the most important person in the room, the patient. Maybe if I had talked to the patient instead of my resident, I would have found out that he was a drug addict who shoveled snow the day after my surgery for drug money, and he ruptured his tendon. He may have ruptured anyway, but this case taught me a very valuable lesson. For the last 10 years, I spend most of my time teaching the patient during the surgery. Then I can teach the resident in the spare moments. I have a full hour to teach patients during a flexor tendon repair how to get a good result after. So let me explain the theory of the movement that we're going to do when Amanda starts you moving on Friday. The goal is to move it just a little bit so it doesn't get stuck, but not to move it too much so that it rips apart. It doesn't take much to rip this apart because the stitches are only about 1/10 as strong as your tendon. You're not going to use it at all. You're just going to move it just enough to keep it moving so it doesn't get stuck. What's the most important rule when we get you to start moving it?
I can move it, but I can't use it.
Important rule when you start moving it on Friday?
I can move it, but I can't use it.
So it's Monday morning. You've got no Advil, no Tylenol on board. And we're 3 days after the flexor tendon repair. What's the most important rule when we let you move it today?
I can move it, but I can't use it.
Intraoperative patient education is one of the most important things to get a good result. One of my favorite questions to the patient during a flexor tendon repair is, what were you planning to do this week? Many will say, oh, I was going to take my children swimming. No, you can't do that with a flexor tendon repair. And I explain to them why they can't take their children swimming. You help a patient change their life plan. Having a flexor tendon repair needs to have a change of life plan. Who is better than the surgeon to guide a patient for why they need to change their life? If they don't change their life, they will rupture their repair. In summary, the 7 most important things to consistently get good results with clean-cut flexor tendon repairs are at least a 4-strand, very solid repair with 1 centimeter bites. I like Jen Boateng's 6-strand M-Tang repair. A bulky repair, 10 to 30% bulky. Judiciously vent as much pulley as you need, no more than 1.5 to 2 centimeters. 2 centimeters in long, skinny fingers, 1.5 centimeters in short, fat fingers. Intraoperative active full fist flexion and extension testing to make sure there's no gapping and to make sure you have vented enough pulley to allow the repair to move. Intraoperative patient education, up to half a fist of true active movement post-op, and relative motion flexion and extension splints that I don't have time to talk about tonight. Wide-awake surgery also will give you much better results in tendon grafting and tendon transfer because you can get the tension just right, not too tight, not too loose. The patient can see the result at the end of the case and knows that their hand can work if they follow the therapy. And Walant has taught me that 2-stage tendon reconstruction is obsolete in my practice. Let me show you this case. This man I operated on in Honduras. He had a 6-month-old injury with all flexors cut. We injected 110 milliliters from proximal to distal, always reinserting in numb skin. Then we dig a tunnel between the A2 pulley and the bone. You just get your scissors in between the A2 pulley and the bone, and you make enough room for your tendon graft to go through. We then put the FDS, flexor digitorum superficialis grafts through those A2 pulleys, and we don't need a 2-stage Hunter rod. It took 2 tries to get the tension right. Our first was too loose. The second was just right. Once we knew the right tension to sew the FDP to FDS tendon grafts, here he is at the end of the case with a good result. Here he is at 3.5 months after the surgery, and here he is at 2 years after surgery. He sends me his videos from Honduras, and I did his hand therapy from Canada via WhatsApp. This is a tendon transfer in a patient who cannot extend the thumb and the wrist. And what we did was we did flexor carpi ulnaris to extensor digitorum communis and palmaris longus to extensor pollicis longus. 120 milliliters of 1/4% lidocaine with 1 in 400,000 epinephrine everywhere we're going to cut. We saw that he had good excursion in flexor carpi ulnaris, even though he had a very bad injury where the motor nerves of the forearm were. We rerouted flexor carpi ulnaris to reroute and weave that into extensor digitorum communis. Then he extended his wrist.
Just try to straighten out your fingers as best you can.
Are you amazed?
Okay, now try to lift up your thumb. Awesome.
Nice.
Oh my God.
I didn't get it.
Wonderful. Okay, lift up your thumb again. Beautiful. What are you thinking when you lift up your thumb?
It's been so long.
No, but seriously, are you thinking move your wrist or are you thinking move your thumb?
Move my thumb.
Totally cool.
It doesn't feel like my hand.
Okay, and make a fist. And lift out your thumb. Straighten out your fingers.
He started to cry. This was the first time he saw his thumb extend and his wrist and fingers extend in 2 years. Patients who see this during the surgery will not forget. They will work hard with therapy after the surgery because they know in their heart it's going to work. Patients need to see their hand during the surgery to move it. You need to take the drape down because they cannot feel the hand, so they don't know where it is in space unless they see it with their eyes. They don't know what their hand is doing. Take the drape down, let them see their hand so that they can move it for you. Don't yell at them to move it if they can't see it. They cannot do it. Walant has also taught us that you don't need to learn tendon transfers. Most of the tendon transfers people do immediately on the table. Here, he lifted his thumb with palmaris longus, and he was thinking, lift my thumb. He was not thinking, flex my wrist. Walant has taught us that patients can do tendon transfer movement right away without having to spend a long time learning it. This is Amir Ahmad from Malaysia doing a triple tendon transfer of the radial nerve palsy. So this is palmaris longus to extensor pollicis longus, pronator teres to ECRB, and flexor carpi radialis to extensor digitorum communis. You use up to 200 milliliters of 0.25% lidocaine with 1 in 400,000 epinephrine. On the left, everywhere that is blue is subcutaneous injection. Where it's pink is periosteal injection. You can see these videos in slow motion if you Google Shalimar Abdullah, Amir Ahmad, radial nerve tendon transfers. This is free open access in Plastic and Reconstructive Surgery Global Open. You don't need a subscription. It's open access. You can see the videos on how to inject the local and how to do the surgery wide awake.
Let's talk about what we're going to do for the next 3 weeks. Okay. Slowly this time. And straighten out.
We test the stability with
It's not
active
going anywhere, so that's
movement.
good. Does it look crooked to you?
It's better if I sat up.
Yeah, go ahead, sit up.
Can I take it out and look?
Yeah,
Do that little bit.
yeah. Okay, that's it. You only take it to pain, never past pain.
We start movement at 4 days after surgery because we tested the stability of the K-wires during the surgery. We taught the patient that at 5 days after surgery, they can move a little bit without pain. If they don't move with pain, if they listen to their pain, they will not get K-wire infections. And the stitches are not there because this is closed reduction. And here he is at 4 weeks after K-wire surgery, 1 week after the pins are out. You can do early protected movement with K-wired fingers, just like you do early protected movement with flexor tendon repair. I've been doing this for many years, and my results of finger fracture surgery are much, much better than when I was a young surgeon and used to put them in a cast for 4 weeks. I would never do that today. That leads to stiff fingers. Nice x-rays, stiff, useless fingers. This is how to do a digital block in the fat, not in the sheath, between both digital nerves. This is called a simple block. Single injection in the middle of the proximal phalanx with lidocaine and epinephrine. Watch me pinch the skin into the 30 gauge needle so that it hardly hurts in this lady who's very scared. So at the count of 3, just try not to move, okay? You're gonna feel 3 little pinches, okay? 1, 2, 3, very good. Oh, you hardly moved a muscle. You were very good. You inject this over 1 minute. It hurts less than if you inject it over 10 seconds. And this hardly hurts at all. This is Amir Ahmad again, who has published many of these. He published the first distal radius fracture, the first elbow fracture, the first clavicle fracture, and he's also done tibial fractures, acromion fractures, ankle fractures, all wide awake. And he does this for patients who cannot afford unnecessary general anesthesia. General anesthesia is very expensive. Or for patients who are too frail for general anesthesia. If they have bad lungs, a bad heart, it's not safe to put them asleep. It is much more safe to give them pure local anesthesia, just like at the dentist. This is distal radius fracture, wide awake, being done in Taiwan, in 3 cities in the United States, in Colombia, in England. I could show you other videos from Portugal, from Morocco, from Kenya. All over the world, people have started doing distal radius fractures wide awake. I am a plastic surgeon. In my city, the orthopedic surgeons do distal radius fracture. I do not. So I do not have experience doing this, but orthopedic surgeons all over the world are doing more and more long bone surgery wide awake. This video by Steve Kohler from New York City is a both bone forearm fracture reduction in a child. This is how we prepare the Walant solution. 50 milliliters of 1% lidocaine with 1 in 100,000 epinephrine is extremely safe. 7 milligrams per kilogram. You have this in Mexico. The plastic surgery literature has taught us that you can use 35 milligrams per kilogram and still have safe blood levels of lidocaine. So if you stick with 7 milligrams per kilogram, you are extremely safe and you do not need monitoring. You do not need EKG, blood pressure, etc., etc. And if you need more volume, you just add saline. So just remember that 50 milliliters is extremely safe. And if you need more volume, you just add saline. So if I need 100 to 200 milliliters of volume, like for a radial nerve tendon transfer in the forearm, I add 150 milliliters of saline to 50 milliliters of safe lidocaine with epinephrine. If I only need 100 to 150 mils, I add 100 mils of saline. If I need 50 to 100 mils, like for an ulnar nerve or basal joint arthroplasty, I add 50 mils of saline to 50 mils of 1% lidocaine with 1 in 100,000. For most small procedures in the hand, like flexor tendon repair, carpal tunnel, trigger finger, fractured metacarpals, I use 1% lidocaine with 1 in 100,000 epinephrine because I don't need more than 50 milliliters. 0.25% lidocaine with 1 in 400,000 epinephrine, like you saw me use for the 4 tendon grafts in the hand, is extremely effective up to 3 hours. You can do most of your operations in less than 3 hours. The key to good local anesthesia is dilute a large volume everywhere 2 centimeters beyond where you will dissect, manipulate a broken bone, insert a K-wire, or put in a screw. There are 2 problems with lidocaine and epinephrine. The first is the epinephrine rush. Every time I inject, at the end of every injection, I warn the patient, you may feel shaky, like you've had too much coffee, or you've just seen a polar bear, or like you are very nervous. It's not your nerves. It's my drug. It is normal, it is temporary, and it will go away all by itself in 15 to 20 minutes. Do not worry. You are not allergic to it. Cálmese. The second problem with lidocaine and epinephrine injection is fainting. This is a vasovagal attack, and that happens because there's not enough blood going to the brain. You avoid it by always injecting patients lying down. Do not inject patients sitting up. Recognize that patients are going to faint even if they're lying down. The patient will say, I'm not feeling very well, or I think I'm going to be sick. When it happens, put your hand under their knees and pull up their thighs. 2 liters of blood from their thighs goes directly to the brain. More blood to the brain. Take the pillow out from under their head, put it under their feet. More blood to the brain. Put the bed in Trendelenburg. More blood to the brain. This takes me about 15 seconds to do. This will have patients feeling much better in less than 2 minutes. This is what I do every time I think someone might faint, and it solves many problems. At least 3% of patients who get Walant are going to faint. This is how you solve the problem. This is Dr. Joshi from England. He is an anesthesiologist who uses Walant all the time in patients who have high comorbidities like ASA3 or ASA4 because it's safer to use Walant.
Rather than just having plan A and plan B, I'm able to have plan C and plan W to help plan Walant. They're extremely at high risk where they can't have a general anaesthetic, they can't have a regional anaesthetic, and they need something which I know is going to work and is going to be safe for them. So I think it really has helped me in those sort of circumstances where I think, well, I can't do plan A, I can't do plan B, and then have to do Walant. So it's made a big difference to my confidence in where I can apply the Walant technique, use the local anaesthetic, the confidence to know that actually this technique really does work.
So safe anesthesiologists have started using Walant because it's much safer than putting people to sleep sometimes. This man died 6 months after I fixed his carpal tunnel. He had metastatic lung disease. I operated on him because he couldn't sleep at night because of his carpal tunnel pain. I operated on him in my office, sitting up with his oxygen and his daughter, Suiha, watching the surgery. And he died. The anesthesiologists would not put him to sleep because it was not safe. I agree, it's not safe, but it's very safe to do him awake with local anesthesia. His daughter wrote to me 6 months after he died, and she wrote, "Dr. Lalonde, thank you so much for operating on my father and letting him sleep for the last 6 months of his life. His carpal tunnel would not let him sleep. He was awake every night. After you operated on him, he slept much better for the last 6 months of his life. Thank you." It was a beautiful letter that she wrote. Not many patients do that. Most serious complications of hand surgery are actually complications of sedation anesthesia, not surgery. Surgery does not cause thromboembolism or nausea and vomiting or urinary retention or malignant hyperthermia or aspiration pneumonia. These are terrible, and they are all caused by sedation, not by surgery. If you do not give people any sedation, they have zero nausea and vomiting. All anesthesiologists agree that less sedation is safer than more sedation. The safest sedation is no sedation. We were once taught that the world is flat, and before 1950, we were all taught that you should not inject epinephrine into the finger. We now know that that's not true and that the world is not flat. If epinephrine really does kill fingers with extremia, it is extremely rare and only in those with severe pre-existing ischemia. And it is reversible with phentolamine, which is available in Mexico. You are more likely to kill a patient with sedation than you are to kill a finger with epinephrine. The risk of dying of general anesthesia in the United States for a healthy person with elective surgery is 1 in 100,000. It is 40 times higher in some countries of the world. The risk of killing a finger is much less than that. Phentolamine reverses epinephrine vasoconstriction in the human fingers. This is level 1 evidence where 18 hand surgeons were injected in both hands at Dalhousie University, my university. These are my hands. I was injected 3 times with lidocaine and epinephrine in this hand, followed by saline. In this hand, I was injected 3 times with lidocaine with epinephrine, followed by phentolamine. And you see the phentolamine 1 hour after injection, reversing the epinephrine vasoconstriction. Phentolamine does work. It does reverse epinephrine vasoconstriction. So if you have a white finger and you are nervous, inject phentolamine. I have injected more than 5,000 fingers, and I have never needed phentolamine. And I have been injected, these are my own fingers. I have been injected with lidocaine with epinephrine over 80 times in my own fingers. Every paper that I have ever done, I was injected first. I had 1 in 1,000 epinephrine injected in my left long finger, 100 times stronger than what you're injecting. And you can see that my finger is still alive. Epinephrine does not kill fingers. Epinephrine does not kill fingers. However, it's blamed for killing fingers. In this case that we published, after 3 trigger fingers, epinephrine was blamed for the blisters and the tissue necrosis that followed. But this patient actually put her fingers in very hot water, trying to get the feeling back after surgery. You can recognize water burns from patients burning themselves by reactive hyperemia at the base of a blister. If this whole finger was ischemic, you would not get reactive hyperemia at the base of the blisters. You have replanted fingers. A replanted ischemic finger doesn't look like these 3 fingers. These are burned fingers.
At the count of 3, you're going to feel a little poke, and I'm going to ask you to try to not move, okay? 1, 2, a little poke.
This is carpal tunnel surgery.
And I really hate needles, just despise them. This needle was nothing, absolutely nothing. It kind of pressed on my hand 3 times, and then you put the needle in, and it wasn't uncomfortable. And then in a few seconds, it all went away.
I felt the first poke. It was not painful. Not even a twinge. No discomfort whatsoever.
No discomfort whatsoever. There's a tiny, tiny prick, which is not even worth mentioning.
I didn't need to have any blood tests done. I didn't need to have the chest x-ray done.
No tests.
Well, I did not have to go in for tests, as opposed to waiting in line and having tests and then going back another day for surgery. I had to do none of that.
Why anybody would want to go into a hospital and actually subject themselves to a pilot test and everything for no reason just makes no sense to me.
I had my own clothes on and I knew to wear a blouse that we could just roll the sleeve up a bit. I didn't need intravenous. I had no tourniquet on my arm.
I ate before the surgery. I ate directly after the surgery. Like I said, I was not nauseated whatsoever. 0 pain before, during, and after the surgery. That was fantastic. It takes an hour and 15 minutes to do, and then you're back to your daily routine afterwards.
I suppose the whole time I could have been here would have been maybe an hour at the most.
I mean, I don't want an anesthetic unless I have to have it. Well, because it's the anesthetic that gives you the problems in the recovery period, much more so than whatever it is you had the operation for.
For one thing, when you're out, you're out. You have the wake up period. A lot of people are sick. Then the drugs that they give you to stop you from being sick and for the pain and all the rest of it, there was none of that.
And I have a few medical conditions and I am on medication. Nothing changed.
I found it very informative and very comforting that I was able to speak to the surgeon, to have him tell me what I should do, what I should not do afterward. It gave me all that information, and I could hyper-focus on that information at the time because I wasn't doing anything else.
My questions were answered while I was there.
So I paid strict attention, took it to heart, did exactly what I was supposed to do, and I was amazed at how well it turned out.
So I inject 20 milliliters for carpal tunnels. It takes about 4 minutes to consistently get almost zero pain with a carpal tunnel injection. If you inject it a little bit slowly, you can teach the patient during the injection. That time is not wasted. So these patients are all sitting in my office. I inject 3 or 4 patients before I operate on the first one. So these patients who have their hand up, they have been injected and they're waiting for their surgery. This is before COVID. And you wait because it takes an average of 26 minutes to have maximal epinephrine vasoconstriction. I like to wait at least 30 minutes before I cut. So if I inject the first 4 patients, my nurse gets the first patient ready for surgery. After I inject the 4th patient, I operate on the second patient, or on the first patient. While my nurse changes the room, brings the second patient in the room, I go inject the 5th patient. She and I, 1 doctor, 1 nurse, we can do 3 carpal tunnels per hour, relaxed. Nobody else in the room. Only 1 nurse and me and my secretary to meet them in the front. That's all. And I get paid per carpal tunnel. I am not on salary. So the more carpal tunnels I do, the more money I make. And I tell my patients before they come, after we put in the local anesthesia, you will wait at least a half an hour. It's like baking a cake. You put the cake in the oven, you have to wait at least a half an hour. So bring a book, bring your phone to entertain yourself because you're going to need to wait. This is cubital tunnel release. I use 60 milliliters of 0.5% lidocaine with 1 in 200,000 epinephrine. You can see the tumescent local anesthesia 2 centimeters beyond wherever you're going to cut. This is a very comfortable position for the patient, and this position is much easier to take out the ulnar nerve. Much easier than when the arm is by the side with a tourniquet. And because there's no anesthesiologist, no tourniquet, this operation becomes much easier. And I close these incisions with buried 5-0 monocryl sutures, so there's no sutures to take out, same as in carpal tunnels. Now I want you to look at this patient's face. He's very comfortable with his shoulder like that, but watch when he brings his arm down. Oh, I can't put my shoulder that way, doctor. It hurts so much. But during the surgery, it didn't hurt at all, right? Right. Thank you, doctor, for not hurting my shoulder during the surgery. And this is exactly what it looks like with field sterility when we operate on cubital tunnels. This is a very comfortable position for surgeons to do cubital tunnels. But you can do it with the patient prone on their abdomen or on their side. You pick the position that's most comfortable for the patient. You can do Lacertus surgery. So Lacertus surgery is decompression of the median nerve at the elbow by dividing Lacertus fibrosis. Lacertus syndrome is like carpal tunnel of the elbow with simple, effective, wide-awake surgery. All you need to do is divide the Lacertus fibrosis. You do not need the big, long incision like you read in David Green's book for pronator syndrome. Just divide the Lacertus. This is Dr. Elizabeth Hagert from Sweden dividing my Lacertus 9 years ago. I had weakness of FPL, FDP2, and I still had numbness after my carpal tunnel. Dr. Hagert fixed my problem. This is where we inject the local anesthesia to do the Lacertus release. 60 milliliters of 0.5% lidocaine with 1 in 200,000 epinephrine. There's injecting the local. There's the incision. There's the Lacertus fibrosis seen from up above, seen from the patient's head. We divide the Lacertus fibrosis just like we divide the transverse carpal ligament. And we can resolve numbness that's incompletely resolved after carpal tunnel release. So if someone is still numb after a carpal tunnel release, like I was, I should have gotten better, but I didn't completely get better until I had my Lacertus released by Dr. Hagert. If the patient complains of weakness, measure FPL, FDP2, and FCR power. Press on the median nerve under Lacertus fibrosis with your thumb. Does that hurt? Is the palm numb over the thenar eminence? If all those things are so, do a wide-awake Lacertus tunnel release. So what did you think about being awake? What would you say to your friends if they said, oh no, I really need to be asleep to have this operation done?
I didn't feel a thing. It was so quick, completely painless.
Right. So the second story, true story I want to tell you about is that local anesthesia, even big volume local anesthesia, like to reduce a tibial fracture or an ankle fracture or a radius fracture, does not hurt if you inject it properly in 2021. I've been in practice for 35 years. For the first 25 years of my practice, I hurt people when I injected local anesthesia. 16 years ago, I learned how to not hurt people when I inject local anesthesia. You are never too old to stop hurting people. You want your patients to think you are a magician, not a torturer. Aim for 0 pain of local anesthesia and 0 pain of surgery. These are the 13 rules of local anesthesia so that you don't hurt people. The first is use smaller needles instead of big needles. I don't have time to go through all of these 13 tips, just a few. My favorite weapon is a 27 gauge needle on a 3 cc syringe. That's a 1/2 inch needle. I don't use big needles like 25 gauge needles anymore. Smaller needles hurt less going into the skin, and they force me to slow down and be patient. The most important rule about the freezing is the don't move rule. If you pull back, then the needle comes out, I have to stick it in 2 times. If you don't move, it hurts just 1 time, okay? So try not to move. And at the count of 3, I'm going to put the needle in, so don't move, okay? 1, 2, 3. Pinch the skin into the needle. Sorry for the little sting there.
Nothing at all. I'm surprised. Compared to what I've been putting through, like with this.
So you were kind of petrified of the needle, right?
You have no idea.
Right, because you hate needles, right?
Can't stand.
Right. How much did this one hurt?
Out of like 1 to 10?
Yeah.
0.2.
Okay.
0.2, not even 1.
Okay, good.
Like really 0. I barely even felt it.
Good. This is for de Quervain. Do not inject into the sheath. That hurts. just like trigger fingers. Do not inject into the sheath. 1, 2, 3, good. You hardly moved a muscle. So at the count of 3, just try not to move, okay? You're gonna feel 3 little pinches, okay? 1, 2, 3, very good.
Well,
away.
what my dad says is always take a deep breath and hold it for a little bit until it doesn't hurt.
That's a great idea.
Yeah.
So at the count of 3, I'll tell you when to take a deep breath, okay? Okay, you ready? Okay. 1, 2, take a deep breath right now. Oh, what a good girl you are. Oh, what a good girl. It's almost finished hurting. Can you please tell me when it's not hurting at all anymore?
Not hurting anymore.
Oh. There's a whole chapter in the Wide Awake Hand Surgery book on how to talk to children and how to do Walant in children. We published this paper 9 years ago. 25 consecutive medical students and residents were taught hole-in-one local anesthesia, then scored by patients on their first carpal tunnel injection. 75% scored a hole-in-one. That means the patient only felt pain 1 time during the whole injection process. 25% scored an eagle. That means the patient felt pain 2 times during the whole injection process. No patients felt pain 3 or more times. Anyone can inject local anesthesia with very little pain if they follow the simple rules. I have sent you this PowerPoint presentation. Dr. Bonfil has sent it to you. This is a link to a lecture that's all about how to not hurt people. You can see the lecture on YouTube. You can download it to look at it on your own computer with these 2 links. This is the 3rd and last story. We're almost finished. But this story is extremely important. You can move a lot of your hand surgery out of the main operating room for more efficiency, more affordable for your patients, and therefore more accessible for your patients who have no money, who can't afford anesthesia from an anesthesiologist, and who cannot afford unnecessary main operating room expense. Evidence-based sterility has permitted Canadians to take minor hand surgery out of the main operating room. This is how more than 90% of Canadian carpal tunnels are done. No gowns, no hat, no drapes all over the patient. We're not operating on their feet. We're operating on their palm. So just the front part of the hand is prepped and draped. We published a series 10 years ago, 1,500 consecutive cases, 6 surgeons, 5 cities, and only 6 out of 1,500 cases got only minor infections, no incision and drainage, no antibiotic, no IV antibiotics required. Only 4 patients got oral antibiotics. And this is a very safe infection rate of 0.39%. We proved it. Many other surgeons have started publishing on the safety of field sterility with minor hand surgery like carpal tunnels, trigger fingers, and putting in K-wires. This is the garbage for a carpal tunnel from the main operating room. It's 4 times as expensive, 10 times as much garbage as the same carpal tunnel done in a minor procedure room with field sterility like we do most of the carpal tunnels in Canada. In Canada, we used to do them in the main operating room with all of this expense and all of this garbage, trash. Now, most of us do it this way. Infection difference? 0. No difference in infection outcome. This paper on evidence-based sterility I have sent you. You can also Google it and read it. There's all of the evidence that you can use to explain to your administration why you can move hand surgery out of the main operating room. These are papers from the United States showing that it's safe to put K-wires in with field sterility. Field sterility and Walant have changed the way we do almost all trauma in many Canadian cities for the last 30 years. Instead of doing it at night, we do it Monday to Friday, 9 to 5 during the day, outside the main operating room, when it's convenient for me, not when it's convenient for the operating room or for an anesthesiologist. And we're doing flexor tendon repairs, K-wires, open reduction of hand fractures with K-wires. This is augmented field sterility. If I think I'm going to open a finger fracture, I put on a gown and put half sheets on the patient. But if I'm just pinning a baby Bennett fracture like here, and I'm not teaching a resident how to do it, I just put on gloves and towels. If I was having a knee prosthesis, I want the full spacesuit, because if you get an infected knee prosthesis, that's terrible for a patient. He might have an amputation, and it's very expensive for him, not just in money, but in time, and it's very expensive for the hospital. But if somebody has an infection after a carpal tunnel, it's not the same as having an infection after a knee prosthesis. Most carpal tunnel infections, which are rare, respond very well to oral antibiotics and without great harm to the patient. So we should not treat all surgery equally when it comes to sterility, because an infection after a carpal tunnel is nowhere near as serious as an infection after a total hip. It's a totally different thing. This is allowing surgery to be done in places like Ghana in a much more affordable way. In Ghana, most patients before 2017 could not afford to have hand surgery. They started a minor procedure room in Ghana in February of 2017. This is me. I was president of the American Association for Hand Surgery. And this is Scott Cozen. He was president of the American Society for Surgery of the Hand. We opened this first Walant room in Kumasi in 2017. They did 358 cases, because now patients could actually afford hand surgery because they didn't have to pay for unnecessary anesthesia, and they didn't have to pay for unnecessary main operating room sterility. 4 years later, in 2021, they're doing 500 cases a year in the Walant room, which is outside the main operating room in Kumasi, Ghana. This is making hand surgery affordable for people in Ghana and in many other countries. The same thing is happening in Kenya. In Kenya, in the last 18 months, 4 hospitals have started wide-awake hand surgery in minor procedure rooms. This is a wide-awake distal radius with K-wires in Ghana that happened 2 months ago. These are papers from the United States showing that the cost of surgery in the main operating room is 7 times as much as with Walant, with 10 times as much garbage. For surgery centers, it's twice the cost and 5 times the garbage. So many papers out of the United States showing that Walant is cheaper, safer, more effective than conventional surgery with sedation and a tourniquet. This is my last slide. In times of COVID, the British Society for Surgery of the Hand, the British Orthopedic Association, and the Orthopedic Trauma Society 1 year ago in April recommended to all orthopedic surgeons to use Walant as much as possible so that patients did not have to go through the main operating room where the risk of COVID is much higher for all of the operating personnel. You don't need 10 people in a room to do a carpal tunnel. You just need 2 people, 1 surgeon and 1 nurse. Much less COVID, much safer. Thank you. I'm going to stop sharing my screen now.
Thank you very much, Dr. Lalonde. It's an amazing keynote speech, and it's very, very, that's incredible, your technique. Maybe I don't know if we have questions from the people in the auditorium.
Fantastic. Can you see my face now, Dr. Bonfil?
Yes. I can see.
Okay, thank you.
Well, I have a question. Do you have a problem with the Walant, by example, intoxication with lidocaine or cardiac troubles?
Yeah, that's a very good question. The answer is no. So lidocaine is a very, very safe drug, even if you get it intravenously. The emergentologists and anesthesiologists inject up to 100 milligrams of lidocaine slowly, intravenously, in patients with multiple trauma. It takes all their body pain away. Lidocaine is very safe in safe doses, and we never go beyond 7 milligrams per kilogram, which is ridiculously safe. So no problem with lidocaine. With epinephrine, the half-life of epinephrine is 1.7 minutes, the intravascular half-life. And even if you get small amounts of epinephrine in the bloodstream, it's no more than you get if you have, I don't know, if you're in a car accident or if you drop something and break a glass in your kitchen or whatever. And many, many surgeons all over the world have never had a problem, including me. And the dentists use epinephrine all the time. They've been doing it for 60 years. And their literature also shows that it's very, very safe. Will somebody someday have a heart attack during Walant? Maybe. People have a heart attack all the time in their sleep when they're walking down the street. You know, it may happen. I'm not saying it's not going to happen, but it probably will not happen. But if you are worried about epinephrine, you can use a lower concentration. Dr. Teddy Prasetyono uses 1 in a million epinephrine all the time in Indonesia, and he says he has great vasoconstriction. Or you can monitor the patient in the main operating room, like with traditional monitoring. You can do that. It's still safer than putting somebody who's got heart disease to sleep. That's for sure.
Okay. Well, we can see the Walant technique is like a Klein solution for the aesthetic surgery. It's more or less. Okay.
Exactly. Dr. Klein was a dermatologist, and he taught plastic surgeons how to use tumescent local anesthesia for liposuction. So plastic surgeons learned it from the dermatologists.
Yeah.
And plastic surgeons are very used to local anesthesia for skin cancers and things.
Yeah.
So it's easier a little bit for plastic surgeons than for orthopedic hand surgeons to get used to the idea of big volume local anesthesia.
Okay. Well, we have only congratulations for you, doctor. We don't have questions. Thank you very much for your time. Thank you for your all concepts and tips and tricks for the Walant surgery. It's very clear for many of us, and thank you very much. I think, and I hope it's not the last presentation of for our association, and maybe in another time without no great COVID problems, we can you can back to Mexico, please.
It would be a great honor and privilege to speak to you again. And Dr. Bonfil, thank you so much for this opportunity to share what has made hand surgery a lot more fun for me over the years. I started with general anesthesia in a tourniquet, so in the 1980s. I know what it's all about. But every time that we got into something new, it's just made it better and better and more fun and safer and better results. So I know that the surgeons in Mexico and the patients in Mexico, if they start, they're going to love it.
Okay. Doctor, thank you very much. Y bueno, pues a todos nuestros interesados en esto, esperemos que les haya gustado, que hayan aprendido y que tengan una mejor visión de lo que es la técnica de Walant. A nuestro auditorio los invitamos a suscribirse a nuestro canal y si les ha gustado este video, sus pulgares arriba y activen la campanita. Muchas gracias y hasta el próximo mes. See you later, doctor. Thank you very much.
Muchas gracias.
Chao.
Hasta luego. Chao.
Bye.